Do any of you have a view about whether non-health benefits should be taken account of in the cost-effectiveness analyses, since sometimes they can be very large and sometimes change the ranking significantly? You know I do.
I think yes.
Yeah, so that's one of the other consideration I think governments need to consider, and there's some uncertainty or disagreement among health economists whether to include that or not, but I think there are forceful arguments for doing that, and especially in low-income countries where there is an absence of other welfare-enhancing systems.
Thanks. So Richard Cookson, University of York, England. I like this way of looking at the trade-off problem, the Toby's approach, which makes clear, so that the slope of those lines gives you a trade-off, a weight, you know, how many poverty cases averted are we willing to sacrifice, you know, are worth the same as a death averted. I think that's a more sensible approach than, dare I say it, than Ole's proposal, which is to treat it as a sort of tiebreaker. When you're, I think that's the same as lexical ordering, but I might have to think about it. So, you know, it seems to me that, you know, moving someone out of poverty or vice versa is worth something. It's important, it's valuable in the same way that saving a life is valuable. So there's a trade-off there if we think it's valuable. So that's one point. And the second question I wanted to raise is about Ole's presentation is when you take into account individual burden of disease, the sort of quality adjusted life expectancy that someone has, do you want to estimate that, as in the Global Burden of Disease study, in a sort of straightforward way based on diagnoses, your medical condition, or do you also want to take into account social risk factors like socioeconomic status and, you know, lifestyle behaviour, smoking, drinking, all that stuff? Yeah, so that's a question for you.
Okay. So just briefly on the last issue, I think you can group patients in different ways, and it might often be useful to group them according to risk factors or diagnosis or in different ways. So yes, that's a matter of choice, I think, and depending on what kind of information you have. And you could have presented a lot of the same information according to risk factors. But they are biased. We know a lot about risk factors for having a heart condition or other of these medical conditions, the risk factors for mental disease, for other types of disease, we lack a lot of this evidence, so that's more difficult. I agree that these indifference curves are a good way of approaching this, but I disagree with you that using the tiebreaker is a kind of a lexical ordering. It's more like giving it a little bit of weight. So that was my little opening for that consideration. That's all I wanted to do, I think.
We're going to take two questions, and I want to keep because of timing, keep the comments and questions.
Okay. Thank you very much. I'm Musa Sakou from Mali. Just a very specific question regarding the key factors, the key services, like in the context of Sub-Saharan Africa. The list of the key services you have mentioned, malaria, TB, are very relevant. But now, definitely, we have also some of the disease called NTD, neglected tropical disease, where we were high daily, and I don't see too much comment on these. And these are very important now if I want to say about the quality of service and the benefits of health service in developing countries like Africa, if you don't consider these NTDs. For example, I was very impressed about the trichase surgeries. From rank 1 to rank 3. Maybe it's surgery quality, but also I think because of the program on trachoma, which is based on only the administration of azithromycin to avoid the complications. So these are some of the factors we have to, and if also to reduce the complication of maternal birth, we have to consider some of the many pregnant women are heavily infected with intestinal worms, which can affect anemia and also complications. I think these are some of the things also key issues to consider when we are talking about health services. Thank you.
Can we just take one more question?
Hi, Mariska Meus from WEMOS. I'm starting to get the feeling that we are burying difficult ethical questions beneath a thick layer of formula, curves, graphs, numbers. And I'm not trying to say that these things are not important to help make difficult decisions. Certainly, people need them. But let's face it, it's, for most of us, it's not us making these decisions when we're talking about low-income countries. And I'm missing part of the picture here, which is who is making these decisions on what services. And we need to look also at the processes. Also looking at it from a human rights perspective, as Alicia mentioned, that the process is important. Is it participatory? Is it transparent? Who are making these decisions? How is a society organizing these procedures? And I'm thinking about the case of Cuba that we heard about yesterday, where the people served by a certain consultoria come together every 3 years after a survey. They discuss the results, and then they together define what kind of services they are going to need in the coming time. So I was hoping to hear a little bit more also about that aspect of what services to select.
Tessa, you want to start?
So let me tackle that last question. I think we are quite concerned about processes as well, but the processes, and I think Norm can very much speak to this, but I mean, we in WHO work with processes which we try to get as much participation as possible, particularly with national health strategic plans. And it's very hard to start talking about a good process if you don't start with data. And I think that's what we suggest we start with on the effectiveness of the intervention. Then the Ministry of Finance starts also with giving a budget ceiling, which can go up and down, depending on how you negotiate it, but there is a starting point. And then I think that's where you talk about is the discussion on the values. Is this happening in the countries? Very few would actually are raising this. What we do have are advocates who are strong on the ground for specific diseases. So I think this particular approach is fairer in the sense that it gives everybody a voice. And you start with the data. And the advocates are there. They have their advocacies. But you start with the data, and you really don't deviate from, that's your starting point, and I think you put the greatest weight there. And I think we could, several of us have had the process of, maybe you mentioned the consultatoria or whatever in Cuba every 3 years. We actually did something more elaborate in Tanzania. In Thailand when we actually were helping Thailand to try to decide the question on inclusion of renal replacement therapy, and that was the great experience we had with the 2 Dans and Widole, where we had how do we call it? Deliberative polling was the mechanism used in Thailand, where the Thais organize really, this is true democracy in the sense that the sample population was randomly chosen. They chose the same sampling frames as in the household surveys. So we got a whole range of people, but they were educated. That was the starting point, and it was measured. They were asked about their views before, and after some education was given, and they were asked to make choices. So this is very elaborate, and I would really recommend this in terms of the deliberative part. And I think that is what is missing, the deliberation.
Although one comment to that, they need to be very carefully structured to be useful.
Yeah, the questions have to be, the options actually. The options that you discuss should actually be the actual options on the table.
Just two responses. The non-communicable diseases that you didn't see many examples of, there will be a lot of evidence on this now from the DCP3 project that Dean Jameson is organizing and coordinating. There will be a lot of evidence, and already the WHO have published more than 500 interventions in the BMJ last year, showing the cost-effectiveness ratios for many of them, and many of them are quite cost-effective. So what I wanted to show that you need to see all this together and look at the distributional impact of including some of them, but you cannot include all of them. And I would argue that this approach of defining key services, and if you label them rights or entitlements or key services, you could think of them as a kind of entitlements that people know that they are entitled to, and that the progressive realization of access to these key services is what universal coverage is about, and also what the right to health is about.
Toby, do you want to comment on processor NCDs? Can we have the last two questions?
Okay. I'm Marima Ali. I'm from CMI Norway. And when I listened to your presentation on priority setting, what came into my mind was, what about the political economy side of priority setting? And maybe if you can say something about issues regarding the political and institutional constraints, whether you should consider that when you say priority setting in different countries. Thank you.
Hi, my name is Eka. I'm from Georgia. I have worked at the Ministry of Health, and now I'm doing the research on universal healthcare coverage at the Maxwell School of Public Administration. Thank you. I have just one comment about positive list, which was talked now. In Georgia, we have such kind of experience from the very, very past history when we had universal health coverage with positive lists of services, and it happened that when you don't have the exact system for good monitoring and evaluation and control, medical facilities and physicians often use these lists to adverse selection or to change the real diagnosis and diseases, and because it's usually people do what they are for what they are financed, so they apply the reality to the positive list diseases, and it finally leads to the damage and failure of statistic, unfortunately it's so. And the second question is that what do you think if discuss two alternatives of bundling the services? First, to establish the quite broad and comprehensive universal coverage of health services, and say that we apply with these services to just poor population or some kind of advantaged people. And the second alternative would be that create different kinds of bundles of packages, considering the alternatives you were talking today now, and apply to different kinds of people, groups of people with different kinds of co-payments and different kinds of packages. Actually, it may be very difficult to administer for especially developing countries. Thank you.
Does anybody want to take that on? Any last comments before we close?
Well, with regard to the political economy, that's obviously a challenge. My approach would be to try to push them in the direction of helping their population as best as possible, rather than, say, the more powerful groups in the population, not to build in a system to skew it towards the kind of power base. However, to only push as much as as we realistically can on that, in order to avoid them just ignoring the advice. One really relevant consideration, I think, which we'll want to think about, is how to move from the status quo of current service provision to some ideal provision. If they currently include things which we wouldn't want to include in the key services, but they only include them for a small proportion of the population, say, should we grandfather that in and say, let's put all growth in the health budget into the new key services, but not reduce the existing services? That's one potential approach which would help to avoid the kind of loss aversion, where if something that's already been given is now taken away, that could be so unpalatable. So I think that's something we definitely want to think about as to how we could give advice to ministers, even if the ministers actually would like to move towards this system, but they're worried about being kicked out of office if they actually make such radical steps initially, even if they would have rathered that they'd done that all along. So that's something on that.
30 seconds. Tessa? Okay. So we're going to close the session.